Hi, my name is Kirsten McCulloch, and I will be presenting a case study about Meg Newton, a 32-year-old female diagnosed with multiple sclerosis, specifically the relapsing remitting type. MS is defined as multiple neurological symptoms that occur as a result of lesions on the brain and spinal cord. Damage to the myelin sheath creates an abnormal inflammatory response within the central nervous system. Damaged nerves cannot send electrical signals through neurons at a consistent rate. So this can cause symptoms like tremors, vertigo, pain, fatigue, gait impairment, cognitive impairment, and mood disorders. This can also affect the autonomic nervous system, which can result in bladder, bowel, and sexual dysfunction. MS is not contagious, but there are patterns in people who have this condition. So people from age 20 to 50 are most likely to have MS. Geographically, people from places that are farther away from the equator are going to have MS, and this could possibly be because of vitamin D deficiency. Females are also 3 times more likely than males to have MS, and this could possibly be because of estrogen. MS occurs in people from Latin, Asiatic, and African American descent, and it's going to be most common in Caucasians of Northern European descent. Recent findings suggest that African American women are more susceptible to MS than previously reported, and this could be due to implicit bias, vitamin D deficiency, and possibly estrogen. Diagnosis is going to take a while, so it's important to notice these signs early on. In order to test for MS, you can do a neurological exam, you can do an MRI brain scan, cerebrospinal fluid analysis, or an evoked potential test. Because MS is going to affect the central nervous system, it's going to affect your motor control, reflexes, and perception. So a neurologist is going to carry out a series of tests based on balance, coordination, reflexes, and senses. And this criteria is somewhat similar to the McDonald criteria. So these are some of the common symptoms that you're going to see in people with MS. As an occupational therapist, you're going to be focusing on things like cognitive impairment, motor issues, sensory issues. You can also look at visual and vestibular systems and how those are going to affect your daily life. If you don't have the ability to see, it's going to be really important to change the environment so that it's more accessible. And of course, we're also going to be looking at fatigue and pain and trying to reduce those symptoms as much as possible. Meg Newton is our case study, and her first episode occurred approximately 5 years ago. She's had trouble with eyesight and trouble reading fine print and labels. But because these symptoms went away after a few weeks, she was never seen for these symptoms, and this is going to look a lot like relapsing remitting multiple sclerosis. So we see a relapse 10 months later with blurred vision, double vision, pins and needles, muscle weakness, and temporary paralysis as a result of that weakness. So with these symptoms, it's possible that there could be lesions in areas like the optic nerve, motor pathways, and sensory pathways. So in order to obtain a diagnosis, we're going to put Meg through an MRI and a visual evoked potential test. So visual evoked potential, or VEP, is going to measure how long it takes for the brain to respond after a visual stimulus. So this checkerboard screen that you see is going to send an electrical signal through the optic nerve, and a response delay from the brain of about 10 milliseconds or more can signal that there's been damage to the myelin. Because Meg's VEP showed prolonged latency, this means that it took her brain much longer to respond to that electrical signal. So this is going to show that she does in fact have MS. And this test was primarily used to diagnose MS before MRIs, and it's a little bit faster and a little bit cheaper. So the myelin sheath is a very important part of MS. It's a good way to remember it, MS, myelin sheath. The primary purpose of myelin is to insulate the axon. The insulation prevents depolarization of electrical impulses and increases the conduction velocity of the nerve. So MS is going to degrade this myelin, and this is going to slow down that conduction velocity. As the condition progresses, oligodendrocytes can also be attacked, and once these cells are damaged, myelin cannot be reproduced, and that's going to permanently change how quickly the brain is able to respond to stimulus, which is what this VEP is going to measure. So this is a good way to quantify damage to the myelin, because the rate at which electrical signals travel is directly related to the quality of the myelin on the axon. Action potential is going to initiate this movement of an electrical impulse away from the cell body and down the axon. This impulse is going to jump from node to node, and these nodes are called nodes of Ranvier. And within these nodes, there's going to be sodium and potassium pumps that facilitate rapid depolarization and repolarization of action potentials. So damage to myelin and the axon itself is going to slow down the action potential and the conduction velocity, and change how the nervous system functions. So without myelin, the nerve cannot easily propel the impulse towards the axon terminal, so it's harder to have communication. The best way to treat MS is going to be a disease-modifying treatment. Primarily what we're going to focus on here is interferon beta. There are multiple others, but IFN beta is going to be one of the most effective treatments that we see, and it's going to be much more effective at a higher dose 3 times a week. So we see a lot less improvement in those that get an injection of IFN beta once a week compared to those who get a higher dose 3 times a week. And this medication is going to help reduce damage and inflammation of nervous tissue and help build up the blood-brain barrier. And the blood-brain barrier is a really essential part. This is where the immune cells are going to cross over into the central nervous system and attack the myelin, so it's important to build that barrier up. There is not a lot of research on the long-term effects of IFN beta and other immune modulating drugs. Most clinical trials have been 2 to 4 years long, so there isn't a lot of evidence to support this medication's long-term effect on disability. As an OT, it's our responsibility to encourage physical autonomy and independence in patients with potentially disabling conditions like MS. So an OT's responsibility is to address the unique challenges of each patient as they continue with their everyday life, In Meg's case, she has difficulty with vision, specifically reading fine print and labels. This could mean that she doesn't have the ability to do necessary tasks like pay bills or find medications and take them on time. So, as an occupational therapist, you find solutions for those problems. You're also trying to resolve problems that could potentially occur in the future. So during relapse, this may also limit her higher order functions, like her ability to drive, shop for groceries, or cook a decent meal. And you want to be able to prepare someone for that and have mechanisms in place that will help them. Occupational therapy is dedicated to teaching people different ways to address the challenges that come with the many possible symptoms that MS could provoke. And these symptoms are probably going to interrupt those activities of daily living. And occupational therapy is going to get you back to those activities or find new ways to do those activities in a way that is safer. Meg's living conditions might need to be changed to help create an accessible environment for someone potentially losing their vision. So a white cane for sensing the environment around her could be a possible solution. And OT's treatment should be modified for current conditions as well as possible limitations in the future. For a general summary, MS is going to be a very complex condition that requires a wide range of rehabilitation therapies, as well as disease-modifying therapies. Interferons are going to play an essential role in that treatment. Dose and the dosing schedule is going to heavily impact how effective that treatment is. And all other medications for MS are primarily used for symptom management. And these are my references.